Hi, I'm Jeff, the OT Dude. Welcome to this episode of the NBCOT exam prep course from the OTDUDE Academy. If you're just watching this from YouTube, be sure to enroll in the free course to get the most out of it, including study guides, interactive games, quizzes, and more. For example, after watching and reviewing this video, quiz your knowledge with the Splints matching game for these upper extremity conditions. The link is in the description. This video will go over the upper extremity disorders, including the conditions and injuries, including for the hands. There will be a lot of information, so feel free to take breaks and watch this in several sessions. Let's get functional. Let's review some general OT interventions when working with fractures. Before you even work with the patient, you'll want to identify the weight-bearing precautions and how they will affect functions such as ADLs. Starting from the most strict is non-weight-bearing, then touchdown weight-bearing for balance, partial weight-bearing, which is about up to 50% weight-bearing as tolerated, and finally, full weight-bearing. In real life, patients often have polytrauma, and multiple fractures are possible in different locations at the same time. So therefore, they will often have multiple weight-bearing precautions that apply to them at any given time, and adding to more of the complication for you and your patient that you need to follow during therapy and outside of it too. With fracture interventions, I want you to think about orthopedics and their healing phases. For example, callus formation takes about 2 to 3 weeks, and bone union takes about 4 to 6 weeks. Characteristics and considerations, such as for surgery by the orthopedist and therefore OT management, include unstable versus stable fracture, displaced versus non-displaced, open versus closed, comminuted or not, and rotational spiral fractures. Two common surgical approaches are ORIF and X-fixes. Otherwise, conservative management is usually a cast or protection of some kind. The goal of orthopedics is straightening and alignment of the bones, right? So you can either immobilize, such as in the very beginning of the healing phase, or allow for mobilization if the bones are stable. 3 immobilization techniques include casting, bracing, and our OT favorite, splinting. As an OT, you will want to encourage active range of motion and strengthening of surrounding structures as they are not affected and have no limitations compared to the fractured ones. Typically, patients can start early mobilization of the affected structures, but only with orders and when cleared by an orthopedist. More evidence is also building for the intervention of early mobilization for many conditions, but especially for fractures, especially after external fixation. Typically, early mobilization is a good thing to do as long as there are no contraindications or if the surgeon's protocol does not prohibit it. One thing to watch out for, though, is a recent administration of blood thinners, in which the patient would be on bed rest until, say, 24 hours later. Other interventions include patient education, including education for safety and falls, caregiver education, modalities for pain as well as promoting mobility and function, wound care, pain management, edema management, and psychosocial, such as the fear of falls or anxiety with having things like an X-fix coming out of your body. I'd be probably a little bit freaked out too. As patients are expected to heal and have a good prognosis overall, oftentimes with the majority of fractures, they can use adapted strategies and adaptive equipment for the promotion of ADLs and other interventions set by the goals, such as for managing at home. An evaluation should ask questions such as the environment, any DME, barriers, and so on. Upon discharge, you'll want to provide a home exercise program, HEP, that includes range of motion and strengthening. With that out of the way, let's start with fractures of the upper extremity. we will go proximal to distal and end at the hand and the digits. Outcome measures you can use include the monofilament, 2-point discrimination, grip strength, MMT, range of motion. Remember with the MMT to not just go through the motions automatically and do testing of all the joints. Pay attention to the contraindications. For example, if they are non-weight bearing in the elbow, then you don't want to crank on the elbow for MMT. You can always do NT in your documentation for not tested. Some others to consider, but you don't have to memorize this, include the 9-hole peg, box and blocks test, Purdue pegboard, Fugel-Meyer, Wolf motor function test, the DASH, Able hand, Jepson-Taylor hand function test, Michigan hand outcome questionnaire, and Crawford small parts dexterity test. You should also make good use of observation and watch for edema, color changes, the presence and strength of the pulses such as distally, temperature and temperature changes, pain, and infections such as drainage from pin sites like X-fixes. And remember that these tests should not replace the evaluation of real occupations, what we do as OTs, such as for ADLs. All right, let's get into it. A humerus fracture typically occurs at the surgical neck or midshaft. A midshaft may have radial nerve involvement. And what happens with the wrist when you have a radial nerve injury? It is responsible for wrist extension. So a midshaft humeral fracture with a radial nerve involvement results in wrist drop. The orthopedic management of a humerus fracture includes the use of like a brace or shoulder sling like the ones you often see on TV with like the white fabric. And research provides strong evidence for the use of immobilization slings for non-displaced humeral fractures, but really doesn't specify which specific kinds of slings. But an important one to remember for a humerus fracture is the Sarmiento brace. It allows for function, which is important. So with occupations, you can begin things like adaptive ADL training. To remember this, the Sarmiento brace sounds kind of like the brand of cheese Sargento that I eat, that I get from like Costco. And if you look at their logo, it kind of has these two squiggly lines, kind of looks like two humeri. Fractures in the elbow typically occur at the olecranon from high velocity falls or a direct blow to the elbow. Elbow fractures have some of the highest complication rates due to fracture dislocation injuries that may involve multiple fragments and adding to the healing times overall for the prognosis. And elbow fractures have a high risk of leading to contractures such as Volkmann's contractures and subsequently loss of function. A sign of Volkmann's contracture is ischemia involving bluish or pale skin, decreased hand sensation, and severe pain. There may be radial nerve involvement and decreased elbow range of motion, as well as forearm supination and pronation. Early rehab after olecranon fractures includes casting it about 60 degrees of elbow flexion and advancing it to 90 degrees as tolerated. A posterior elbow splint may be fabricated to replace the postoperative plaster ones that the surgeon may use. And once full active range of motion is achieved, the brace is discontinued as the patient has regained full range of motion of the elbow, right? They can begin with full active range of motion and advance to passive range of motion to regain extension and strengthening. It is not until this stage that they actually are typically allowed to do some weight bearing through the elbow though. Moving on to the forearm. One classification to know for fractures of the forearm is the type 1 to type 3 system. Type 1 to 3. Type 1 is for non-displaced, type 2 is for displaced, and type 3 is for comminuted. With non-displaced or type 1 fractures of the forearm, they can often benefit from a long arm sling. Next is the radius, and more commonly, the distal radius is fractured as people often reach out to them and use their wrist to catch or break their fall. An extended wrist results in a Colles fracture with dorsal displacement of the wrist. Because a Colles fracture results in dorsal wrist displacement, you would use a volar wrist splint for temporary immobilization. A Colles fracture may compress on the median nerve. And less commonly, a flexed wrist fracture usually occurs from high energy trauma. And this results in a Smith's fracture, resulting in volar or palmar displacement of the wrist. Let's review metacarpal fractures. They are named after the location of their fractures. For example, a Bennett's fracture involves the first metacarpal base of the thumb. A thumb spica splint would be used for Bennett's fractures. Here's a picture of singer Tony Bennett, unrelated to the Bennett fracture, with two thumbs up to help you remember this. The most common type is boxer's fracture, involving the fourth or fifth metacarpal, named after typically when one throws a punch that connects with the fourth and fifth rather than the second or third knuckles. An ulnar gutter splint can be used for a boxer's fracture. With wrist fractures, a complication is nerve injuries. Two common nerves that may be injured include the median and ulnar nerves. For example, patients with median nerve injuries experience similar symptoms as carpal tunnel syndrome. Carpal tunnel syndrome is due to the compression of the median nerve that runs through the carpal tunnel. Both types of compression may result in numbness on their associated sides of the innervations of the hand. Median nerve injuries affect, say, the first to fourth digits, and ulnar affects, the ulnar side, such as the fourth and fifth digits. Moving on to the carpals. Remember the mnemonic, so long to pinky, here comes the thumb? The most common fracture of the carpals is scaphoid fracture, which you would use a thumb spica splint for. The top of scaffolding for construction projects resembles sharp spikes: scaphoid, scaffold, spikes, spica splint. Lunate fractures are rare and are also immobilized with the thumb spica splint as well. With lunate fractures, there is a risk of Kienbock's disease, which is a vascular necrosis of the lunate, resulting in lunate osteonecrosis, or even death of that location. Kienbock's can result in wrist pain and later stages carpal arthritis. A thumb spica splint is also used for most of the remaining carpal fractures as well. To remember Kienbock's with the lunate fracture, there is an emphasis on the O in the pronunciation and spelling. And of all the carpal bones, the lunate kind of resembles a circular shape that looks like the letter O. Fractures in the phalanxes are also possible. The proximal is the most common, with the thumb and index involving the loss of PIP motion. That's it for fractures of the upper extremities for the NBCOT. Let's review the upper extremity syndromes and traumas for everything else: the muscles, tendons, nerves of the upper arms. Let's review the two big C's, or C's. First, complex regional pain syndrome, CRPS, and CTD for cumulative trauma disorder. CRPS is considered a vasomotor dysfunction, and the hallmark is pain that is disproportionate to the injury. There's type 1 with onset after a noxious event, and type 2 after a nerve injury. In addition to pain, symptoms of CRPS include swelling, stiffness, contractures, skin discoloration that's blue or shiny red, sweating, hair growth, temperature changes, muscle spasms, and weakness. CRPS may progress through 3 stages: the traumatic stage, dystrophic stage, which results in the glossy appearance and redness and heat, and the last atrophic stage, with the skin cooling down to be dry and cool and a decrease in experience of pain. Again, CRPS has 2 types and 3 stages. For OT treatment, the big contraindication you must remember is absolutely no passive range of motion or painful intervention. You can use gentle, active range of motion, but again, no passive range of motion. You can remember this rhyme with COM, no PROM. With COM, no PROM. COM being the calm in complex. Also, respect and manage pain. You can use TENS, continuous passive motion, CPM, and splinting for pain control. Address edema early on and sensitivity issues using desensitization techniques. Tendon glides may also be incorporated as well for patients. You may want to provide what's called a vasomotor challenge, as this is a vasomotor dysfunction. Makes sense. And this includes things like stress loading, i.e. floor scrubbing, temperature biofeedback, and positional changes. And remember, no splints and no casting. One side note is regarding the orthopedics or the surgeon's guidelines and protocols. As an OT, you must follow each individual surgeon's protocol, and each one has their own sometimes, after surgery when it comes to OT practice and interventions like immobilization with splints, the types of exercises such as tendon glides and blocking exercises, progressive exercises, stretching activities, strengthening, and so on. Despite what you learned or reviewed that is textbook or typical for OT conditions and interventions. The other big C is cumulative trauma disorder, CTD. The disorder basically defines what it is. Repetitive trauma, RSI for repetitive strain injury, overuse syndrome, it's the same thing. It involves soft tissue trauma from repetitive forces over and over. It is a broad umbrella term for more specific diagnoses that you are probably already familiar with or learned in OT school, such as epicondylitis, carpal tunnel syndrome, and tendonitis. Symptoms include pain, inflammation, muscle fatigue, and sensory impairment. CTD has a scale from 1 to 5 based on how quickly the pain resolves after a triggering activity. Grade 1 resolves quickly after the activity, all the way up to grade 5, which results in the inability to work due to the severity of the pain, even with no activity. OT treatment involves the 2 M's, modify and move, or movement. Modify activity demands to avoid repetitive motions, and modify performance patterns to incorporate rest. Modify the context and the environment, and use movement, different kinds, not the same repetitive ones that cause the disorders. If the CTD for the patient is a workers' comp case, then functional capacity evaluation, FCE, and work hardening may be used. Let's review the flexor and extensor tendons. The tendon zones are kind of similar for the extensor and flexor tendons, but they have specific landmark differences on the hand based on which side of the hand you're looking at. So for extensor tendons, they are divided into zones starting from 1, just going distal to proximal from the thumb towards the wrist. The zone for the other digits besides the thumb also start distally from zone 1 to zone 7 proximally, ending at the carpal bones and wrist as well. The flexor tendon zones similarly start from zone 1 at the fingertip, going to zone 5 at the wrist. Complications of tendons in the hand are pain, edema, and loss of function at the tendon injury site. Thankfully, the intervention for tendon repairs is easy to remember. Tendon glides to promote excursion. You'll want to start this early and combine this with modalities which not only can help with the pain, but also to promote motion and function. Common modalities include heat and NMES. The usual range of motion is incorporated as well, but strengthening begins later on until the healing and recovery after surgery. 2 protocols to remember are Duran and Kleinert. The Duran protocol is an early mobilization protocol that uses passive range of motion of the digits. Exercises are done with wearing a dorsal blocking splint. The Duran does not use any rubber bands or any active muscle contractions. In contrast, the Kleinert protocol does use rubber bands as traction for the digits, and instead of passive range of motion, the patient performs active digit extension combined with passive digit flexion from the rubber bands. Note that extension is active, but flexion is still passive for range of motion. To remember the Kleinert versus Duran, think of the brand Calvin Klein for Kleinert underwear, and the elastic band part that holds it in place in your body, kind of for the underwear. It has a natural kind of tension that keeps it below your waist, right? Think of this as passive flexion. Flexion because it goes towards your body from the article of clothing. But to take off the underwear, you have to actively pull outwards against the underwear band, right? Which you can think of as extension, as it is external from your body. Remembering that the Kleinert protocol has this band and the different active passive range of motions, then you know that the Duran protocol is the one without it. So no rubber band and no active range of motion in flexion extension. One common question is, well, what happens if the patient cannot follow the protocol, such as due to cognition or motivation or something like that? Then protection such as with a cast may be an option in the first few weeks. So that was that for the tendons. Let's review some nerve injuries. It's the major three that you already know: median, ulnar, and radial. As these are nerves, remember that there can be both sensory and motor deficits, such as sensory loss on the affected side. So now's a good time to review hand signs and some tests that may be present with some of these conditions. Keep in mind that some of these signs may be present with multiple conditions, so they are a general kind of clue and not a definitive test or a diagnosis. But the NBCOT might go into these and give you a clue of what's going on and mention it, like the sign. So remembering these signs actually can tell you or clue you in on the deficit and what it kind of looks like and give you more of a visual when you're kind of just looking at text on a screen. I encourage you to even make the sign in person and visualize it, kind of like counting with your fingers instead of doing mental math for like a math problem or like adding a check. So reduce your mental cognition and just use your physical hand and muscle memory to reduce the brain power during the real exam. Tinel sign is a pretty broad test for many things like the median and ulnar nerves, to name a few. Tinel signs may indicate 1. Carpal tunnel syndrome for the median nerve compression at the wrist, 2. Guyon's canal for the ulnar nerve and the wrist, and 3. Cubital tunnel for the ulnar nerve at the elbow. Tinel kind of sounds like tunnel, and this reminds me of like carpal tunnel or cubital tunnel when you do these tests. Froments is the one where you kind of pinch a paper and you pull away to test for pinch strength, and it kind of sticks up for a positive sign. Froments sign may indicate ulnar nerve palsy and a weak pinch grasp of the thumb. Think of from, like when you send a letter, it is from you handing it to your favorite crush or something. Gene sign involves thumb hyperextension at the MCP that may be present with a claw deformity. Kind of looks like a pair of jeans. I don't know. Wartenberg sign involves the 5th digit having a space from the 4th digit when you try to adduct them. And it kind of forms a W when you separate the thumb from the other 3 fingers. In the middle, you have a W. Finkelstein's test, think of it as the opposite of the thumbs up when you tuck your thumb inside your fingers, kind of like a turtle. Your thumb acts and tries to be smaller like a pinky. Finky rhymes with pinky. So Finkelstein, Finky, pinky. Phelan's test is a test for carpal tunnel when you flex both of your wrists and push your dorsum of your hands against each other. To remember this, if you have really bad carpal tunnel syndrome and you use the pen to write or type an essay like for an exam, you would fail. Phelan's test, failing the test. A median nerve laceration or compression results in the hand of benediction or Pope sign due to the wasting of the thenar eminence and atrophy. And when the patient tries to form a fist, there is poor thumb opposition. and also poor pointer and middle finger flexion at the MCP and PIP, forming this bishop's hand, but it works over here, so that's why you get flexion. And to me, this kind of makes sense because of the nerve laceration on the median side of the hand with the flexion, so it affects these, which innervates. And it's also called ape hand because of the wasting of the thenar eminence. The splint for conservative treatment or non-op is a static thenar splint that promotes the web space. Post-operatively, you can use a dorsal blocking splint, and you should also promote active range of motion, passive range of motion, and tendon glides. Ulnar nerve laceration or compression results in the claw hand or claw deformity. There is wasting of the hypothenar eminence and the intrinsic muscles of the hand. It results in a weak power grip. A claw hand deformity is formed because of the inability to extend the fingers at the ulnar side for digits 4 and 5 at the IP joints, and they remain in flexion. The splint used is an anti-claw splint for non-operative and a dorsal blocking splint for post-operative patients. One way you can remember this easily is that a dorsal blocking splint is used for both post-op, median, and ulnar nerve traumas. And if you think about it, like the anatomy for the median and ulnar nerve side for the non-op splints, it kind of makes sense that the thenar splint would be used because it is near the thumb in web space, and the anti-claw for the ulnar because of the claw deformity. Radial nerve involvement can cause weakness in the wrist extensors. So wrist drop, and you would use a dorsal splint. It's also called Saturday night palsy from being intoxicated and resting on a chair or something at the axilla and compressing on the radial nerve. A more serious laceration results in difficulty with fine motor tasks such as releasing. Treatment includes range of motion, strengthening, and nerve glides. Now let's go from proximal to distal again for more specific conditions. Rotator cuff tendonitis involves inflammation or irritation of the tendons and muscles of the shoulder joint. It also is called impingement syndrome, swimmer's shoulder, pitcher's shoulder, or tennis shoulder. And above shoulder level exercises should be avoided, and especially when sleeping, as it can be accidentally put in this position of comfort for some people unconsciously above shoulder level, like sleeping like this, for example. And OT treatment includes pain management and strengthening. A rotator cuff tear results in weakness on MMT in shoulder abduction and external rotation. Someone with a rotator cuff tear would have a positive drop arm test and trouble with above shoulder activities. They may hike their shoulders using their upper trapezius muscles to substitute or compensate for the deficit. Treatment begins with an arm sling and OT intervention for daily tasks. And sling use is gradually reduced to incorporate range of motion, stretching, and strengthening with a focus on progressive tendon forces. For non-surgical patients of rotator cuff tears, they should avoid sleeping with the arm above shoulder level as well as adducted and internally rotated. Start with passive range of motion and progress to active range of motion. Strengthen the scapula and rotator cuff and use isometric exercises. For the surgical repair patient of a rotator cuff tear, a common range of motion exercise for the shoulder are pendulum exercises. But I can't do the sitting down, but they should be pain-free. Ice is a good modality to use as well before, during, and after therapies to help with pain and also for swelling. You can start with passive range of motion in the shoulder for flexion, extension, and abduction. Keep in mind that internal and external shoulder rotation should be performed with the shoulder only adducted and not abducted. An abductor pillow also makes for a great shoulder immobilizer in between exercises. Adhesive capsulitis is also known as frozen shoulder. Adhesive capsulitis results in decreased shoulder range of motion, especially external rotation. To remember this, think about water in chemistry changing from a liquid to a solid. The adhesive part holds the molecules together like water molecules turning to ice and when frozen in the freezer. Frozen shoulder. Research supports various stretches such as abduction and internal-external rotation and some others. However, evidence supporting the use of PAMS is kind of limited for frozen shoulder. Subacromial impingement syndrome results in shoulder pain and functional disability for the shoulder at around 90 degrees into shoulder, almost knocked over my water bottle, into shoulder flexion. For treatment of pain, PAMS using laser and also elastic taping can provide significant short-term relief according to the research. Now let's review lateral and medial epicondylitis. Lateral epicondylitis is also known as tennis elbow due to cumulative trauma and wrist extensor overuse. Medial epicondylitis is also known as golfer's elbow and is due to wrist flexor overuse. The elbow splint is used for both of these two conditions. Nice. A wrist splint may also be used as well to help immobilize the wrist and to keep it from overuse, the cause of these conditions in the first place. And patients should also stretch and progress to strengthening. Now let's review nerve compression syndromes. There's median nerve compression, ulnar nerve compression, and you guessed it, radial nerve compression at the different parts of the upper extremity, such as the elbow, forearm, and at the wrist. The median nerve compression syndrome is called pronator teres syndrome, named for the muscle at the forearm. It's kind of like carpal tunnel for the median nerve, except that it occurs at the elbow. In fact, pronator teres syndrome has the same symptoms as carpal tunnel syndrome. Since it happens at the elbow, the splint would be, you guessed it, an elbow splint in 90 degrees with the forearm in neutral. Ulnar nerve compression of the elbow is called cubital tunnel syndrome. This one is kind of a tongue twister. Cubital tunnel syndrome symptoms includes pain at the elbow and numbness and tingling along the ulnar side of the forearm and hand. A positive Tinel sign may indicate cubital tunnel syndrome as well. Treatment includes the use of an elbow splint as well. At night, patients can wear a splint or a pad so long as it prevents elbow flexion. To remember the elbow syndromes, remember the anatomy of the pronator teres muscle and the cubital tunnel and where it's at. Radial tunnel syndrome. It involves the radial nerve at the forearm near the head of the radius distal to the humerus. It results in pain at the lateral forearm due to radial nerve compression. A long arm splint would be useful for radial tunnel syndrome. Now we are at the wrist. Carpal tunnel we kind of went over already for median nerve compression, but it would have a positive Tinel sign and a positive Phelan sign. Treatment for non-surgical includes a wrist splint in neutral. Carpal tunnel often gets relief from median nerve glides and, of course, joint protection. Okay, what about ulnar nerve compression at the wrist? This is called Guyon's canal syndrome. Remember how Tinel sign also indicates ulnar nerve compression at the wrist? And a neutral wrist splint would be used for Guyon's canal syndrome, and it has the same interventions as the other non-splint interventions for carpal tunnel. Moving towards the end of the video, and we are at the thumb and fingertips now. Gamekeeper's or skier's thumb results in the rupture of the ulnar collateral ligament of the MCP of the thumb. Use a thumb spica splint and focus on thumb range of motion and strengthening. This one is kind of easy to remember because of the gatekeeper's name and the skier's name from the ski poles. De Quervain's tenosynovitis results in an inflamed tendon at the base of the thumb from CTD, cumulative trauma. A common cause is repetitive carrying of heavy grocery bags by the handles. To remember this, De Quervain's kind of sounds like a hard alcohol brand to me or something. Oh yeah, isn't there like a Don Q brand? I don't know, but because I don't drink anymore, but I remember how heavy those alcohol bottles are. So carrying them like functionally in grocery bags over time would injure this area of the thumb. And main symptoms of De Quervain's or Don Q are pain and tenderness at the wrist, often below the base of the thumb. It may be indicated by a positive Finkelstein's test. The splint you would use is a thumb spica splint. Dupuytren's contracture is the thickening and shrinking of the palmar fascia, most common in the 4th and 5th digits. It results in flexion deformity. And it seems that hand splinting for Dupuytren's is controversial and inconclusive, so I won't give you any wrong information. Last for this video, we will review boutonnieres, swan neck deformities, and mallet finger as well as trigger finger. For these, you'll want to know how to describe them anatomically or how to recognize it anatomically at which joint in the digits and in which direction that the deformities are in. Boutonniere's deformity is characterized by PIP flexion and DIP hyperextension. Swan neck deformity is characterized by hyperextension at the PIP and flexion at the DIP, which is opposites of the boutonniere deformity. Mallet finger is characterized by lack of DIP extension. Splints used for all three deformities are IP extension splints, or sometimes called oval 8 or ring splints, for which they look kind of like those cool rings on your finger. Trigger finger, you should know for the exam that the medical term is called stenosing tenosynovitis. Trigger finger often occurs when inflammation narrows the space that surrounds the flexor tendon in the affected finger. If stenosing tenosynovitis is severe enough, a finger may become locked in a bent trigger position requiring external force to extend. A splint that therefore prevents MCP flexion at the specific finger would be used. That pretty much wraps it up. Some other important splints you might want to review are the resting hand splint and wrist cock-up splints. And don't forget to check out the splints matching game in my NBCOT exam prep course to quiz your knowledge of the splints for upper extremity conditions. If you found this video helpful, give it a thumbs up and share it with your study groups. I'm Jeff, the OT Dude. Thanks for watching and good luck studying.